Associate Professor Danielle Hitch. She's going to be sharing with us an overview about long COVID, where we are at and where we're going, its relationship to ME and key takeaways from the work of the Western Health COVID-19 Recovery Collaboration. Her review will cover its impact on participation in daily life, the experiences of culturally and linguistically diverse communities, and reflections on the meaningful inclusion of lived experience experts in both research and the production of an upcoming rehabilitation textbook. Presentation will end with reflections on where research is going in the long COVID space and its relevance to ME. So thank you very much, Dani.
No problems at all. And can you see my slide?
Yes, and you. Yes.
And me. Awesome. That's great.
Yes.
I don't know if that's great actually, but anyway, hello everyone. And good evening. And thank you very much for the opportunity to contribute to this fantastic session. I'd like to take this opportunity to acknowledge the traditional owners of the lands on which my work's been completed or my team's work's been completed. That's the Wurundjeri and the Wathaurong people of the Kulin Nation, and extend my respects to their elders past, present and emerging. So many of you will already know what long COVID is, but I thought I'd just provide an overview to set the scene. Long COVID refers to a persistent, often debilitating symptoms that linger weeks, months, or even years after COVID-19 infection. Just to acknowledge there are some long COVID people who are now in their 5th year. These symptoms can impact any body system or structure and can have a really profound impact on all areas of daily life. Characteristics of long COVID were first described by the World Health Organization, or WHO. However, their definition excludes people whose symptoms could be explained by a pre-existing condition. And in my opinion, that contributed to a really limited perspective on long COVID, which really only focused on younger people who were previously healthy. I therefore prefer the National Academies of Sciences, Engineering and Medicine, or NASM, long COVID definition, which is up on the slide. They describe the condition as a chronic systemic disease state with profound consequences, characterised by over 200 symptoms, including fatigue, brain fog, and PEM. Their definition was also developed with input from patients, which was not the case for WHO, researchers and clinicians, and it really highlights the condition's complexity and evolving nature. I also like that it acknowledges that people with pre-existing conditions can and do get long COVID and the effects it can have on people of all ages. So, as you would all know, long COVID is not the first post-acute infection syndrome to challenge our understanding of post-viral illnesses. For centuries, syndromes like ME and those caused by viruses such as the Epstein-Barr virus and things like Ross River fever, post-polio syndrome and things like that have been around. And they do have some striking similarities. So the slide shows, I guess, a grid which highlights the symptoms and the various post-acute infection syndromes. So there is some overlap. And the conditions often share core symptoms, particularly of fatigue, cognitive dysfunction or brain fog, and post-exertional malaise or PEM. And that reflects their systemic impact. But each syndrome also has unique features due to the distinctive impact of the particular virus that causes them. So, for example, chikungunya, I think I'm saying that correctly, causes joint swelling. And long COVID, one of the hallmarks tends to be a loss or dysfunction in smell and taste, particularly for people who are infected with the earlier variants. But neither ME or long COVID have definitive biomarkers, which really complicates diagnosis and identification. ME does have established diagnostic criteria, but long COVID's evolving definition relies on frameworks like NASM's. Sadly, people living with both conditions have faced really considerable stigma, dismissal and gaslighting, and a significant number of health professionals still firmly believe that long COVID simply does not exist. I had someone say that to me just last week. The sense of history repeating itself has been really very marked for me. I worked with people with ME in a clinic in the UK early in my career, and I saw how they were, quote unquote, treated. So understanding the overlaps and the differences between these two conditions is really important so that we can provide personalised and empathetic care for all people experiencing these conditions. So the Western Health COVID-19 Recovery Collaboration, or WeCover, is an informal multidisciplinary network of clinicians, researchers, and people with lived experience. And it includes members from multiple institutions and diverse backgrounds, but we are more like a collective than anything else. We're not necessarily formal, but we all do hang out together and do some nice research, as you're about to see. So because it's been driven by clinicians and people with lived experience, it's been a really responsive and productive collaboration, and it continues to work closely with our community in an ongoing program of research. So I'll now take you through some of our long COVID research just to paint a broad picture of where things are currently in Australia. I think when we started in 2020, we were probably the only group driven by clinicians that was doing this research, but there is lots of people working on long COVID now. So it's just our little corner of the long COVID world. The first study I'll discuss, and this was the first study we did, really aimed to describe and contextualise how people recover from COVID-19. So it focused on their personal experiences to try and inform public health responses at the time, especially as the country was shifting from an emergency response to living with the virus. So we did narrative interviews with 37 adults from Victoria, Australia, about 6 to 10 months after their COVID diagnosis in 2020. Participants all lived in the western suburbs of Melbourne, which is one of the most diverse and fast-growing communities in the country. And they were mostly female and included many healthcare workers. The interviews explored their personal recovery stories and were analysed using a narrative qualitative approach to really try and capture individual stories. So we had three key themes that came out of this. The first was that people's recovery from COVID-19 infection really varied. Some people did fully recover and very quickly. Some improved quite gradually, and then others experienced relapsing symptoms. So periods of being better and periods of not being better. It was quite marked that a lot of people made initially a full recovery, and then 3 to 4 months down the track, things all fell apart. So it was a few different trajectories. Secondly, recovering for most people meant returning to their normal. So what had previously been normal for them. So it wasn't necessarily about a clear blood test or other medical test. It was actually, am I back to my normal? And it was really related more to resuming daily activities than symptoms disappearing. But a lot of people were going back to their activities, but doing it in a very different way since they'd had COVID. And thirdly, returning to work was really important for many people, especially the healthcare workers, but was clearly very challenging, partly due to fatigue, partly due to the mental health impacts for healthcare workers who are returning to the place where they got COVID, and workplace complexities. So it really highlights the really complex role of social determinants, things like employment and community context when it comes to recovering from a COVID-19 infection. And it highlighted that the experiences of recovery are really diverse and uncertain and very individualised. So the personal stories behind the COVID case numbers are really crucial if we're going to be delivering effective and really inclusive care for people with long COVID and by extension, people with ME. For our next study, we sought to explore how long COVID affects disability, function and quality of life in Australians compared to population norms, and also looking at links to factors like age, vaccination, comorbidities and self-rated recovery. There actually isn't very much long COVID research that includes Australians, so we're really trying to sort of understand it in the local context. So this was a cross-sectional survey of 121 Australian adults with confirmed long COVID in terms of self-reported long COVID, and we recruited them between May and October 2022. So all of these people completed a 10-minute online survey, which was the HUDAS, which is the WHO Disability Assessment Schedule, and also the SF36, which is a measure of quality of life, and some questions about demographics, comorbidities, and their self-rated recovery. 86% of the participants reported significant disability, and the HUDAS scores were actually showing greater impairment based on population norms than 98% of the general population. So really significant impact on people's ability to participate in daily life. The activities that were affected during their lives were affected on 27 days per month, so pretty much every day. And household duties, work, and social participation were the ones that people found most difficult. The SF36 scores showed reduced quality of life, especially when it came to energy and social functioning again. Self-rated recovery strongly predicted better function and quality of life, which really just says that the link between how people felt like they were going overall and what these surveys were showing was very close. So they aligned very closely. Higher vaccination doses, so 4 doses or more, so someone who's fully boosted, were linked to improved emotional well-being, but also to greater difficulties with household and work activities, possibly because people choosing to be vaccinated were people who tended to have pre-existing conditions or were older. Older adults, though, reported less disability related to self-care and household activities, but greater role limitations due to emotional problems. And interestingly, and against what we actually thought, pre-existing comorbidities were not a major predictor of quality of life, disability, or overall function. This is just one of many studies internationally that really shows that long COVID significantly impairs function and quality of life in many, many different ways. So with the assistance of a seeding grant from the Women's Health Research Translation and Impact Network, or Wharton it's called, our next study really looked to explore the unique challenges and experiences of women from CALD communities, culturally and linguistically diverse communities who have long COVID. So a group whose voice really hasn't been heard at all to date. So we completed 30 narrative interviews with women from these communities, and we offered research information and interviews in multiple community languages. A really nice aspect of this particular study was I had the opportunity to upskill 8 of my multilingual clinician colleagues who'd not really done any research before. And it was a really nice way to get them involved in research and for them to reach out to their own communities, but also ensure that we're building the research force of the future. So a lot of these clinicians are now actually doing further research with me. So yeah, that was a really nice thing to be able to do, to build a long COVID research workforce locally. Participants really reported some of the challenges from the pandemic were universal to everyone, but they faced distinctive barriers related to racism, language difficulties, and also migration-related issues. Some people felt really fortunate because they were able to pass as white Australian, which is pretty terrible when you think about it, that people assume that they'll get proper healthcare if they can pass as a white Australian. The cultural diversity was also seen as a strength, and we were very careful to ask questions along that line so that it's not always a problem, particularly in relation to family support and the use of traditional healing practices like herbal teas and things like that. There was a lot of misinformation that our participants told us about, which increased their infection risk. So, for example, there is a myth still circulating quite widely that Black Africans are naturally immune to COVID-19 and therefore they don't need to take any precautions. So this sort of information is still out there and unfortunately leads people sometimes to take risks that they're not fully aware of. Language barriers and medical jargon obviously also lead to misunderstandings and some other issues as well. And we've also looked into the role of gender in long COVID experiences. So this research drew upon over 100 interviews with Australians living with long COVID and some international evidence. We have very limited data from men. If you know any men with long COVID who'd like to be researched, please let me know. But it does suggest that they may avoid seeking treatment for long COVID because they don't want to be seen as weak. And the preliminary data really suggests that men may be at greater risk of PEM for similar reasons because they just kept pushing through no matter what. However, our data is primarily focused particularly on women's challenges and caregiving impacts, but we would like to recognise that people with diverse gender identities also have distinctive long COVID experiences, and they really should be included in future research. So briefly, women who are twice as likely to develop long COVID anyway face really unique issues like menstrual changes and menopause symptom overlap. The number of comments we've had from women of my age saying they just tell me it's menopause is unbelievable. It happens in every interview. But it's also compounded by caregiving roles that hinder recovery. So women carers balancing long COVID and family duties experience really significant energy constraints along with guilt, while systemic barriers like dismissive healthcare attitudes prevent them from getting the care they need in the first place. So gender is definitely at play. So where are we going? So I'll give you a quick overview of where we're at, which is what I've done, and I'll tell you quickly where we're going. So my research group is in the process of developing the COVID check-in, or the CCI. So this was actually a patient-rated outcome measure that we co-designed with 6 people with long COVID. And we're using that to build an online self-management platform for long COVID. Platform will be freely available online, and it's been co-designed still with lived experience experts. And it'll support people with long COVID to identify their needs. And it really focuses in on participation in daily activity alongside symptoms, but more focused on what can you do with your day and what do you want to do with your day. So we developed an algorithm, and that will provide the person with tailored information about supports and self-management strategies. We're not assuming that everyone can get in to see a specialist or access a service. So we're giving lots of information about what you can do just for yourself. And it also spits out an abbreviated version for their health providers. It also encourages people to check back in every 3 months so that the information can be adjusted as their circumstances change. And we're really prioritising high quality, credible information. So anything that we're going to put on here has been really rigorously assessed to make sure that it's good quality information. So we're really hopeful this will become publicly available at the start of next year. But our focus for this year is exploring the sensory differences and challenges that are experienced by many people with long COVID and shared by people with ME. So the aim of a current study we're doing is to investigate sensory processing and function for people with long COVID and people with long COVID with and without PEM. Not everyone with long COVID has PEM. And we're going to compare that to the general population. We're targeting 220 adults, and we're using online, phone, and mailed surveys. And we've done a lot of work with our steering committee to make the surveys as accessible as possible. And we're looking at sensory capacities and interoception, which is awareness of your body, and also function. And as part of this, we are looking to validate the FunCap, which was, as many of you would know, a scale that was originally developed by people with ME, so that it can be used in long COVID research going forward. The thing that stops it from being used often at the moment is a lack of validation studies. So we're actually going to do that. And validating FunCap was identified by people with long COVID as something they really wanted to do. So they're driving this study. I'm just helping them out with it. So it will enhance, rehab and hopefully inform a future control trial of sensory modulation interventions, which we feel may well be useful. And finally, all the research and work we've done with various groups over the past 5 years has come together, and we're publishing this rehab textbook. It's coming out in September. And our real goal with this was to move beyond the phase of people going, what is this? Like, we've got no idea what long COVID is, to what can we do about it? We had lots of our colleagues coming to us and saying, what can we do? We want to be able to do things to support people. So we've pulled all this together. Every chapter has been co-authored by a person with lived experience with long COVID. It's also been peer reviewed by a second person with lived experience. So we feel like we've written something that's respectful and accurate and up to date. And I have to say, the process of co-authoring this has been one of the most stimulating experiences of my career, and I have learnt so much. So finally, there's still much to learn. So from our point of view, the key trends for future long COVID research at least are here, and I suspect they're also relevant to the field of ME. We really should be focusing on questions that are aligned with lived experience, particularly around understanding symptom duration, recovery prospects, and quality of life impacts. Collaborative approaches like the one taken by the James Lind Priority Setting Partnerships, which involve patients, carers, and clinicians, and carers often get left out of this, but should not be. We'll make sure that the research we're doing is meaningful for the people who live with this condition. We need to overcome some methodological problems in our research. However, most long COVID research doesn't have a control group, and that is problematic from a a scientific point of view. But also, it's not accounting for the COVID-19 variants. They all present quite differently. And we need to get better at capturing symptom constellations or clusters rather than just focusing on one symptom at a time, because that's just not how it is. And finally, we really need to get better at data synthesis and sharing. Researchers aren't always good at that, but I've been really lucky to be part of some collaborative groups that have been really collaborative, and the textbook is testament to that. There's a lot of partnerships in there. And we have some things coming up around technological advances like AI, wearable devices, and telehealth, which is really important for access. So there's lots to be hopeful about. That's not to say that it's not doom and gloom for a lot of people. It is incredibly difficult to live with long COVID, but there is a lot of hope, and it's possibly one of the good things that's come out of the pandemic, that we've had a bit of a surge in research in this area, which hopefully can also be translatable across to the field of ME. And the last thing, I just want to acknowledge my co-authors on the textbook, including Julie, who have also put in a lot of work around getting all this information together. So thanks very much, and I'm happy to answer any questions you might have.
Thank you, Dani. That's great to have that overview of what's happening in this space and that overlap with COVID. I don't know if, sorry, long COVID, if we have time for any questions. I know that we're a little bit behind with our time. I can't see any in the chat, so I don't know if anyone had any
Okay,
quick.
if people can email me and I'm happy to answer any questions.
Okay, okay, perfect. Thank you.